city management and evaluation of a patient with syncope. So the syncope is the loss of consciousness due to decrease in the vascular supply to the brain. Here we can have cardiac etiologies, reflex etiologies, or orthostatic etiologies due to decrease volume or decrease in the tone of the arteries that leads to decreased volume of blood flowing through the brain. So the cardiac could be due to arrhythmias or ischemia or decrease in the left ventricular outflow. The reflex one could be vasovagal. Here usually there would be a prodrome like nausea, sweating, or being warm, maybe pallor, something like that. And this is seen with severe stress or pain, micturition, staying in a standing position for a long period of time. So vasovagal or a hypersensitivity of the carotid sinuses, so would be activation of them. If we put pressure on the carotid sinuses, maybe we can produce that. And the other would be situational, that is, for example, in micturition. And the orthostatic ones would include either autonomic dysfunction, for example, in patients with diabetes mellitus or something like that, they are at increased risk of developing orthostatic hypotension. Also, if there is hypovolemia, for whatever cause there is hypovolemia, there would be decrease in the blood that is going through the brain. And so we have a hypovolemia or dysfunction, or let's say iatrogenic in the sense of related to medications like the alpha-1 receptor, alpha-1 adrenergic receptor antagonist. Alright, so these are the ones that we can have. For cardiac etiologies, it will be very student, the loss of consciousness and the regaining consciousness, etc. As well as for the reflexes in the vasovagal, also it is very, very common, very rapid recovering. Alright, now, so we would have this was a way to divide. Now in the clinical way for the management of the patient, we can divide as cardiac or neurological. So the first step is to see if there is syncope or not. So once we know that there is a syncope, then we will proceed. The first step, here we need to ask 3 questions once we know that the patient has syncope. It was the loss of consciousness was gradual or sudden. If it is sudden, it could be either a neurological or cardiac. If it was gradual, then we will think about a metabolic problem, like problem with the electrolytes, glucose, or due to a drug related. So we will do toxicologic exam plus the chemistry, glucose levels, etc. So if it is sudden, we know that it is neurological or cardiac. So the next step is the second question. The second question is the regaining of consciousness was gradual or sudden. If it is gradual, it was a neurological problem, for example, seizures. And where in seizures they are not exactly syncope, but anyway, they will be, for example, seizures. If it is sudden, it would be a cardiac problem. And the third question now, if the patient has this one, so because we're suspecting about seizures, then we will do the CT scan. Now, how would we suspect seizures? For example, instead of vasovagal, the seizure would be suspected, or well, the CT scan would be made. CT scan and EEG. For example, we would do a EEG to rule out seizures if the patient has jerking movements more than 30 seconds. If the patient has, let's say, lateral tongue biting, or if the patient has prolonged confusion after the episode. So if the patient has the postcoital episode that is not seen on the syncope, as we saw on a previous video in the comparison between the syncope and seizures. Alright. And also we would ask for a CT scan if the patient has, that we are suspecting because of seizures, or if the patient has a brain or a head trauma secondary to the syncope. So the patient has the syncope, falls onto the floor, and so there was a traumatic brain injury. Alright. These are focal neurological symptoms. Alright, so now if it was sudden the regaining of consciousness, then we're talking about a cardiac problem. And if this is a cardiac problem, the third question is, the cardiac exam is normal or abnormal? If it is normal, then there was, that is, the cardiac exam is just listening heart murmurs or something like that. So if it was normal, there is no problem with the valve, and so this would be a arrhythmia, for example. So here we will do a EEG. Actually, it is a Holter for 24 to 72 hours if it's going to be outpatient, or a telemetry if the patient is in inpatient care, if the patient is hospitalized. And if the patient, so this could be either arrhythmias or ischemia. So if there is ischemia, we will do the EEG to look for the ST elevation or ST depression, but also we will take the cardiac enzymes. And if the cardiac test is abnormal, that is, we found some murmur, then it could be a valvular problem, or could be the hypertrophic cardiomyopathy. This will lead to decrease in the left ventricular outflow of blood. Valvular problems will include mitral stenosis, aortic stenosis, mitral prolapse. And so to assess it, we will do the echocardiogram. Alright, so the algorithm for the management with the patient with syncope, once we know it is syncope, then the loss of consciousness was sudden or gradual. If it is gradual, then we will do toxicologic screen or the chemistry, etc. If we have no time, we will ask for every one of these things: the EEG, echo, head CT scan, the toxicologic screen, etc. If it was sudden, then it is neurological or cardiac. Then we would ask if the regaining of consciousness was sudden or gradual. If it was gradual, it is neurological problem. If it is sudden, it is cardiac problem, and so we proceed to the cardiologic exam. If it is abnormal, it will be valvular problems or due to decrease on the left ventricular outflow. If it is sudden, it is due to arrhythmias or ischemia of the heart.